And in comparison to the kind of paragraph you get in most medical textbooks, NF1 is something which is hugely ill understood by medical professionals, and we're trying to reverse that. We're trying to educate the medical professionals as well as individuals with the disease. Thank you. I mean, it is the last day of my holiday, but otherwise I'd be stuck in the M6 driving south. So this is much better than the M6, so thank you very much for inviting me. I'm definitely in holiday mood though. Those who know me in clinic know I wear a three-piece suit. I'm much smarter than I am at the moment, so bear with me. I still haven't quite got back into work mode yet. I haven't done actually practice the talk at all about NF1, and I can't cover all the complexities of NF1 in this short period of time, because what I've learned in the last 10 years is that NF1 is hugely complicated, and in comparison to the kind of paragraph you get in most medical textbooks, NF1 is something which is hugely ill understood by medical professionals, and we're trying to reverse that. We're trying to educate the medical professionals as well as individuals with the disease. So I've just been doing this for the last week. I do a little bit of photography. This is where I've been for the last week in Buttermere, a beautiful place, and I've certainly chilled out. But now back to work. So NF1 is this condition. It's an inherited genetic condition. And this is due to spelling mistakes, mutations in a particular gene called neurofibromin. And you really have to kind of get an idea about how complicated the human genetic material is. I've just checked. My computer here, rather old, contains a hard drive which has 500 gigabytes of memory on it, which is quite a big hard drive. But actually each of the individuals in this room have a genetic kind of inheritance of about 5 terabytes. And each of us contain that information in each of the cells of our body, and we each contain about several trillion cells. So the human genome is hugely complicated, and NF1 is caused by a single spelling mistake in one of those genes. So the gene is called neurofibromin. It's a very big gene. It does seem to be quite prone to being mutated to get spelling mistakes in it, which is why NF1 is one of the commonest genetic disorders in the UK. And neurofibromin is a protein that's involved in controlling how cells divide. So that's why you get overgrowth of tissues. You get overgrowth of tissues in the skin, causing neurofibromas. You get overgrowth of those cells producing pigment in the skin, which is why you get the cafe-au-lait patches. And scientists, including myself, I'm afraid, love diagrams like this because they're completely ununderstandable by anybody else. So this is a kind of a diagram showing how NF1, neurofibromin, sits in this great load of complicated pathways that control how cells divide. So neurofibromin NF1 sits in a number of pathways, but they all sit within this rather complicated system called the RAS-MAPK pathway, which is something which we know can cause disease in a number of inherited diseases. Those people who are in the room here who have NF1, who know somebody have NF1, will recognise some of these diagnostic features. And I'm very grateful to Ros Ferner, who's lent me a lot of these slides. So most people will recognise a cafe-au-lait patch. Most people recognise that if you have NF1, you have freckling in your armpits, you have freckling in your groins, you might have some freckling around your neck. These are unusual sites to have freckling. On the left, on my left, you can see the eye of somebody with NF1, and you can see these little brown marks. These are called Lisch nodules, and these cause you no harm whatsoever, but do appear in NF1 and are one of the diagnostic criteria. I can see in the room already several people who have these cutaneous neurofibromas. So you have to have 2 or more of these. This individual's got many of them. Or a more diffuse overgrowth of tissue, a plexiform neurofibroma on somebody's leg. In children particularly, you get problems with the long bones. They become bowed and can actually break, a pseudoarthrosis. And then I'll come on this side. On this image here, this is an MR scan of somebody. And on the MR scan you can see here, or I can see, that these are the optic nerves going out to the eyeballs, and these optic nerves are bigger, they're thicker than they should be. And these are optic pathway gliomas. Again, something which happens very commonly in NF1, which although actually doesn't cause that many problems in adulthood, can cause problems with vision in childhood. Some of the features you get, well, many people with NF1 have a rather large head compared to their body size. They can have these red marks on their skin called angioma, or Campbell de Morgan spots, and I've got these as well. They're quite a common finding in normal individuals, but you see more of them in NF1. In children, you can see the xanthogranuloma, and also you get these pale patches, these nevus anemicus, on this image here. Some people don't have whole body NF1. So when you have whole body NF1, the spelling mistake mutation in the NF1 gene occurs from the very start of when you were made. However, if that spelling mistake occurs in the cells that only grow to form an arm, for example, you can have an arm that has NF1, or a leg, or a strip of skin that has NF1. We call this segmental disease. And it's important to recognise this because people who have segmental disease won't have problems elsewhere in the body. They're only at risk of getting problems within that segment. And so they're free of complications elsewhere. A lot of things look like NF1. And I've seen referrals from my colleagues in neurology saying this person's got multiple cafe au lait spots, do they have NF1? And actually what they've got is just a bit of pigmentation in their skin. There's a disease called Legius syndrome, which was recognised back in 2007 by Professor Legius, which looks very much like NF1. But in that situation, you just get the cafe au lait patches, you might get freckling, you might get a large head, and you might get some degree of learning disability, but you don't seem to get the more serious complications of NF1. And though it's that much rarer, we spend a lot of time now trying to pick out those individuals that have Legius syndrome because we're less worried about potential complications in them. If we're stuck and if we can't count enough cafe au lait patches, then we can do NF1 gene testing. This is something which takes a lot of time. It takes about 3 months to do. It's a very labour-intensive job for the lab to do, but I think actually it's worth it. A, because we learn something about the disease, because we can work out where in the gene the spelling mistake has occurred, what sort of spelling mistake, and therefore we can understand a bit more about why the disease occurred in that individual. The test is very good now. We can find a spelling mistake in about 95% of people. So it's very good to exclude the disease in people that are worried they've got a few brown marks. But actually we're doing it more and more in people who want to try and plan their future families, so-called prenatal testing. So if you want to have a child and you've got NF1, then your risk of passing that disease on to your child is 50-50. So each child you have will have a 50-50 chance of getting NF1 as well. And that child could be more or less severely affected than you. And it depends on individual choice. There is no right or wrong answer, but some individual would just like to see when their child is born, after a few years, when they develop some cafe au lait patches, well, have they got enough on their skin to make a clear diagnosis? And that's fine for some individuals. They're happy to kind of see how it goes. Other people want to know at birth. And if you know the spelling mistake you're looking for, then you can take some cord blood, so it doesn't involve taking any needles to your baby, some cord blood from the placenta, and you can look to see whether that placental blood contains the spelling mistake that caused the parent's NF1. So you know within a few weeks of birth whether or not your child has NF1. You can also test during pregnancy. So there are various ways in which you can get bits of your baby's tissue from the placental sac, for example, and you can look to see whether your baby in your womb has NF1. The problem about testing in pregnancy, there's always an element of risk, so you might harm the baby in some way. And ultimately, you can essentially test before pregnancy. And this is what we call test tube babies, or pre-implantation genetic diagnosis. So essentially what you do, sorry if it's too much graphic detail before lunch, but you take sperm from your partner, and you take eggs from you, if you're female, and you mix them in a test tube. And you fertilise the embryos, or fertilise the eggs, and then grow up the embryos in a test tube for a few days. And then you can see which of those embryos contain your NF1 gene that causes the disease in the parent. You can leave those to one side and then implant into the mum-to-be an embryo which is free of NF1. And that way, you're not guaranteed, but certainly you reduce the risk from 50-50 down to a few percentage points of having a child who has NF1. So it's a very good way of reducing the risk if you want to do that. It's a personal choice, and some people definitely do, and some people, well, just want to have babies the normal way, and that's fine as well, but it increases the options for you. I mean, NF1 has many complications, and I'll try and go through some of them here for you. One of the things we're really key to point out to people, and particularly to schools, is the impact upon learning. So we know that individuals with NF1 can often have a lower IQ than the average, although people with very severe disability are actually relatively rare. But what's more common is that patients just struggle with some parts of learning, and the school system doesn't often cope very well with children that learn in different ways. And so the roles of the specialist advisors, we've got 2, 3 here, is really important going into schools and advising teachers how best individuals can be helped to learn. And as an adult neurologist, I see lots of individuals in my practice who never got that help when they were children. And they've struggled ever since. I hope we are changing things so that in 20 years' time, or maybe 15 years' time when I want to retire, there won't be individuals out there who've been failed by the school system. So it might be ADHD, autism or behavioural problems, all of which can be managed better than in the past. I spend my whole life examining people's nervous systems, and I can detect changes in the nervous system of patients with NF1. Sometimes they can't ride a bike, they struggle to ride a bike, and when I do testing, I find a specific problem with NF1 individuals, and I think it's important to point out that so they can get help to try and improve that particular problem. Reading, writing, speech problems are all affecting NF1. So getting the education system to work better for NF1 is very important. Getting support for schools, physiotherapy, occupational therapy, and specific treatment for ADHD are all available. CAMS is an important way of supporting children with psychological problems. And then for adults, there's literacy support and psychological support, as well as organisations like Nerve Tumours UK. So neurofibromas are a bit of a mishmash of tissue, really. Again, this is taken from Roz's slide, and she's described neurofibromas as being a bit like a wrap or a bit like a fruit cocktail. It contains lots of cells, but they're often very predominant in Schwann cells. And Schwann cells, those cells that surround nerves and help support them. First described by this guy called Theodore Schwann, apparently. And they can come in all shapes and sizes. So you'll experience yourself these cutaneous neurofibromas, okay? Some small ones here, some larger ones here. And these, although they can be irritating, upsetting, cosmetically disfiguring, itchy, they can catch, they can bleed, but they're not dangerous to you, okay? They're not going to turn nasty if they're on the skin, okay? Often we find that GPs are reluctant to refer on to have these removed, but actually I think they should be removed. If they're bothering you, you can get them removed. You can swap them for a scar, but you can get rid of the actual lump itself. The ones I suppose we're a bit more worried about are the ones under the skin. So these individuals here with lumps under the skin and here. And these, again, aren't necessarily harmful to you, but if they start changing, causing new symptoms, growing, causing pain, weakness or numbness, then they're the kind of things you should tell us about. And be very keen to see you very quickly if they do start changing. So, the cosmetic ones on the skin, if they become infected, get antibiotics. You can remove them, and either you can laser them away or cut them. It doesn't really matter whether you use a laser or you use a knife. They're just cutting them away. And yes, they'll all cause scars. But a lot of psychological support is helpful because, of course, how we look, I mean, the internet's full of people, you know, trying to change the way they look, the Kardashian effect. And if you have neurofibromas in your skin, it does affect your psychological status. So getting support for that, I think, is very important. And there's also camouflage makeup and changing faces, an organisation that is there to help people modify how they look. Many people tattoo themselves. So often it's quite difficult because people had so many tattoos that you can't see the cafe au lait patches. And there's no evidence that I'm aware of that having tattoos will increase your number of neurofibromas, okay? So if you want to do that to your skin, go ahead. Not something that I fancy doing myself, but go for it. So plexiform neurofibromas are those neurofibromas that are larger. They contain a multiple load of tissues, so hence the term plexiform. And they cause more of a problem. We will see people with complex plexiforms because they can cause, in addition to the cosmetic problems, they can cause more neurological disturbance. They can affect bladder and bowel symptoms. They can cause problems with breathing, swallowing. They can bleed. So actually within a plexiform, there's actually quite a lot of space, a bit like a TARDIS, I suppose, and you can bleed into it and lose quite a lot of blood into a plexiform. So those of you who have a large, kind of usually quite kind of soft and squishy plexiform, if it does suddenly within minutes start taking off and getting bigger and harder and firm, then consider a bleed into it. And if that's happening, I would go to A&E because you can bleed an awful lot into a plexiform. So sudden growth occurring over minutes, go to A&E, get it checked out, in my opinion. And of course they can become infected. Of course what you'll want to know is a treatment. And I'm afraid we don't yet have a treatment for NF1. But these complex pathways can allow us to understand what mechanisms we could use to treat these diseases. So there's this chemical here called MEK, okay? And you know, it's been thought that if you can target MEK and turn it down or switch it off, then you might prevent some of the problems with memory, learning and proliferation, the kind of growing of cells. And at the moment, I suppose the MEK inhibitors, or MEK-I, are, we're trying to find where they sit in how we treat NF1. They're not a miracle cure, unfortunately. They do seem to reduce some of the symptoms in those individuals that have large plexiforms. You know, big studies here have shown, you know, reduction in volume, but actually our use has been sort of less. It's A, difficult getting hold of the drug, and B, the side effects actually are quite bad in some individuals. But in the chosen number, they actually work very well, especially if you have life-threatening complications. So at the moment it's for individuals with very severe disease rather than to treat people with more general disease, because the side effects probably outweigh the benefits in those individuals. But it's a good start. You know, we're making some progress. We actually have a drug which may treat some of the overgrowth in NF1. Most of what we do, though, is looking out for complications that can occur in NF1. And this is what I do all day, is looking at scans. So I've just talked you through it. So this is a scan of somebody's neck. So up at the top there will be their brain, and then this structure here is their spinal cord. And that's the main nerve that goes between your head and your arms and your legs and your bladder. Okay? And many people have heard of individuals who've had car accidents or motorbike accidents and they've broken their neck. So these are the bones of the neck here, and the spinal cord sits behind those. And the spinal cord is quite squishy. It's a bit like a tube of toothpaste, really. If you compress it, it gets damaged. And this individual has a neurofibroma here, which is causing compression of the spinal cord at the top of their neck. And untreated, that will make them very, very weak. They'll lose control of their bladder and their bowels. So a lot of what I do in clinic is examining people, looking for evidence for neurological signs suggesting that their spinal cord is being compressed. And all that business I do with the hammers and the tendon, you know, the kind of tuning forks and things, all looking for these complications. Some people have lots of lumps inside them, and these individuals we definitely will see in our clinic. So you can see here, that's the liver there, that's the spleen there, These are the bones of the spine, and the white things here are all neurofibromas under the skin. And you may not see any evidence of these on the skin. So a lot of what we do is looking at for individuals like this who have very complicated disease, and any growth in these can cause pressure on key structures like the spinal cord. I suppose what we're ultimately most worried about with NF1 is this tumour called a malignant peripheral nerve sheath tumour, or an MPNST. And these thankfully occur in a small proportion of people with NF1, maybe about 15% over the course of their lifetime. But they're really important to pick up early, because if you don't pick them up early, they are very difficult to treat. So you'll hear again and again when you come to clinic that if you have a lump under your skin that's becoming hard, that's growing, that's causing weakness, numbness, incoordination or persistent pain, then you should be calling somebody. If you go and speak to your GP and they dismiss it, then you should be calling one of us, I suppose. And to give you an idea, a lump that was previously the size of a pea, which over the course of maybe 2 or 3 weeks becomes the size of a small orange or a satsuma, and is painful, hard, and causing neurological symptoms, then you should be calling for help. Okay? And they're hard, they're kind of woody hard. Okay? They're not soft squishy things, they're woody hard. So please don't call us about ones in your skin that are changing over months. Okay? We want to know about ones that are under your skin, growing week by week. And if you tell us about these, we'll see you, usually within a week or 2. And this is what we worry about. So this is a scan, again from Professor Ferner, of an individual who's had a rather complicated series of lumps in their neck. And for whatever reason, the lumps have become more aggressive, they're growing more rapidly. Almost certainly, new spelling mistakes, new mutations are occurring in those already overgrown nerves. And this lump has suddenly got bigger over the course of a few months. And we can see how quickly it's growing because we can do something called a PET scan. And a PET scan allows us to see how quickly a nerve lump is growing. And you can see on the image on the left-hand side, the PET scan shows red, which means it's hot. It's growing very rapidly. And this almost certainly is an MPNST, a malignant tumour, that if it's not removed quickly will sadly, almost inevitably cause the death of the individual who's got it. So we need to do urgent surgery to remove these things, followed up by treatments such as radiotherapy or chemotherapy to try and control the disease. So it's really important, and I can't stress this enough, if you have those symptoms, please contact somebody, and if you get dismissed initially, ask them again or ask somebody else. Some tumours are thankfully much less worrisome. So I talked about optic pathway gliomas. Optic pathway gliomas occur in children, and in some children it can affect vision, but actually thankfully very small percentage really. And actually I see them in individuals who are adults who might have a bit of a lazy eye, or when I look in the back of the eye they've got slight pallor, their optic disc at the back of the eye looks a bit pale. Often they don't realise they're there. Okay? What we do know is if they are growing in childhood, okay, you don't give them radiotherapy. Okay, so if anybody walks towards you with a radiotherapy machine, or walks towards your child with a radiotherapy machine, ask them why they're doing it. Because we know that if you threw lots of x-rays at the brain of somebody who's got NF1, they're more likely to get other tumours appearing over 5 or 10 years later. Okay, so if they are growing, the optic pathway gliomas, you treat them with chemotherapy, chemicals, and not drugs, and not x-rays. You do need to have your vision checked. So we support people having their vision checked every year for the first 16 years of life. When you get into adulthood, well, we all should be getting our vision checked every 12 months, actually, because if we all drive a car, we should get our vision checked. You should look out for other things, like glaucoma, that can affect any of us. And it's important to get your vision checked before you start driving a car. Having your vision checked isn't difficult. You've all had it done before, presumably opticians. Just involve the kind of standard practice, really. And there aren't really kind of words that instill more fear, I suppose, than those two words here, brain tumours. But again, thankfully in NF1, many of the brain tumours that occur don't cause that many problems. We scan lots of people with NF1 and we see abnormalities like this very commonly on scans. And very commonly we scan people year on year on year without any change at all. So again, if you do find that you happen to have a scan which shows an abnormality, it isn't the end of the world. Very few actually cause major problems, and if they do cause major problems, we have very good neurosurgeons who we can work with to actually treat these. But the vast majority of the abnormalities we see on scans don't cause major problems. We just monitor them every year, and as we get bored of monitoring them because they haven't changed in years, we might do the scans less frequently. But there's things which is seemingly very common in NF1 that often don't need treatment. What's more likely to cause problems is problems with your bones. So we know that in NF1 you can get difficulty with bone formation. Bones can bow, they can bend to funny angles, and we know it's due to a variety of issues like low vitamin D. So how many people in this room have low vitamin D? Who's had vitamin D checked? I have. My vitamin D is undetectable in my blood. Okay, I have no vitamin D whatsoever apart from the stuff that I take by tablet. Because we live in the northwest of the UK, there's not enough sun, and we live in places like this without any sunlight, okay? So about 2/3 of people with NF1 and about 2/3 of people in the adult population have low vitamin D, okay? So join the club, all right? But if you've got low vitamin D and you've got NF1, you get more of a problem with the bones. So we know you get lower bone density, and we know you've got an increased risk of fracture. I've got some pictures here, some bones that have gone wrong. So very commonly, you can get this kind of pigeon chest, pectus excavatum. You can get bowing of your long bones, so bowing of the leg bone here. You can get curvature of the spine. And then this is a really extreme example of where the spine is curved due to NF1 tissue around the spine. And then you get this what's called ectasia, where the fluid around the spine has become dilated. And this doesn't cause much of a problem. This can cause serious problems with breathing and spinal cord problems. So again, the kind of thing that we look out for in our service. So to prevent these things, make sure you've got enough calcium in your diet. So although there's a kind of move against some dairy products, actually they're a good source of calcium. Please don't smoke. Okay, smoking is bad for you in every way. Okay, there's not a good thing about smoking. If you need to go to an e-cigarette, do that. We don't know they're safe yet, but we think they're probably safer than smoking. Regular exercise, go and walk up Blencathra or something. Okay, but you don't have to do something that extreme as that. Just do some stepping up and down some stairs while taking the lift. Sadly, alcohol is also bad for you in every way. I enjoy a drink. I've just had probably too much this week. But alcohol is bad for your bones. And of course, get some sunlight. Okay, so get out in the middle of the day. Don't get burnt, but get some sunlight inside you. There are a few things that happen in NF1 as well. Some individuals in this room might find they've got a really, really, really tender spot on their finger. Okay? They're called glomus tumours, okay? They occur under the fingernails and they make your life miserable because they're really, really painful. And if you've got one, we can whip it out, okay? It's quite easy to sort out. We check your blood pressure regularly because individuals with NF1 get blood pressure problems in childhood because of problems with the blood vessels to the kidneys. In adults, rarely because of this problem where you get an overgrowth of a gland above your kidney called the adrenal gland. And this can cause something called a pheochromocytoma. Again, it's treatable. So if you have blood pressure problems, always ask your GP whether or not they've looked for these two complications. For the ladies up here, sadly we know there's an increased risk of breast cancer in women with NF1. And that risk is most obvious between probably age 40 and age 50. So the normal breast cancer screening comes in at age 50 with 3 yearly mammograms. For women with NF1, we would support having yearly mammograms from age 40. It may well be, in the future we'll be saying even earlier, maybe from 35 years of age. But I would certainly suggest that you examine your breasts every month to get a feel for where the lumps and bumps are. So if you do find something which is changing, you can go and see your GP quickly. Headache, this is what happens when you listen to me speaking for any length of time. But migraine is very, very common. We think migraine probably occurs in about half the people with NF1. In the general population, it's about 1 in 8. So migraine is a major cause of problem with NF1. Who gets migraine here? I bet more people get migraine in this room than are putting their hands up. You might not realise it, okay? But if you get headaches which are fairly commonly throbbing one side of your head rather than the other, you don't like bright lights, you don't like loud noises, you're going to find somewhere quiet and dark to sleep it off, then you probably have migraine. Okay, so when you see adverts on television for Anodin, cures, stress headaches, it's almost certainly migraine they're treating. There is no miracle cure for migraine. I get migraine. But you can control migraine. A lot of things that modern society throws at us makes migraine worse. So stress makes migraine worse. Lack of sleep makes migraine worse. Coffee makes migraine worse. And of course all these drug chemicals you can get from your GP or buy over the counter make migraine worse. So if you're taking headache tablets more than 8 or 10 doses a week, you're almost certainly making your headache worse, and you need to be taking less rather than more tablets. Okay, the commonest cause of migraine we see is neurologists. They're people who are overusing analgesics, overusing painkillers from their GP or over the counter. Okay, and I know it seems counterintuitive, but actually if you reduce the amount of headache tablets you take, your migraine will probably improve and go back to the episodic once a month type headache you did have. For the last week I've slept an average 9.5 hours every night. I've been on holiday, it's been lovely. I've not had a migraine. Normally, this time of week, this time of Saturday, I would have one Thursday morning, I'd have one Friday morning, I'd probably have one Saturday morning as well, because normally I have 6.5 hours sleep. Okay, so I'm a really good example of somebody who doesn't sleep enough, who's stressed, who gets migraine, and it's worse by my lifestyle. So getting regular sleep is really important, and we dismiss sleep as being an important factor. We might have difficulty getting to sleep, we might have disturbed sleep, we might be waking up early in the morning with the birds singing or the cars outside, or we might have a partner who snores. And all these things affect our quality of sleep. Depression, anxiety, restless leg syndrome, where you want to move your legs around at night, really common in individuals, particularly in women. Eminently treatable if you know what the cause is. Drugs. Many of us take drugs to kind of get us to get to sleep at night. But actually there's no drug from your GP that can get you to get to sleep at night and give you good quality sleep. They all just basically zonk you out. You don't get good quality sleep. Pain, really common in sleep disorders. And alcohol. We all take a drink, well, I certainly have it in my time. You have a drink before you go to bed to kind of relax you, to unwind. But we know alcohol really badly affects your quality of sleep. So it should be avoided as a way of getting to sleep. So, avoid alcohol. Avoid caffeine from really lunchtime. Caffeine hangs around the system. Okay, and it stops you getting to sleep, it disturbs your sleep. Switch off your mobile phone, your computer, your television, at least a couple of hours before you go to bed. I've got 2 teenage children. Do they listen to what I say? No. But at least you can try, okay? The bright lights from computers wakes your brain up and stops you getting to sleep. Mindfulness, relaxation, aromatherapy, whatever you want to try and relax yourself before you go to bed, okay? Try taking a herbal drink, but just don't have a cup of coffee. I think of this place, okay? That works for me. You've already heard from Rachel about what NF1 clinical nurses can do, okay? And I won't want to kind of repeat what's been said already. But I think they do have a really, really important role. They're very experienced, they know what they're on about, they can help advocate on behalf of individuals with NF1, support for education, telephone support, clinic support, inpatient support. They are hugely important people who work very much longer hours than they're paid for, and so we need to support these individuals. So, just quickly summarise what I think is important. In children, you need to ensure that their development and their schooling is being maximised. Any behavioural problems being sorted out, as well as the usual things like blood pressure, skin, bone, eyes, sleep and headaches, all of which are manageable. In adults, which is what I spend most of my life doing, we always check for with blood pressure. Well, why don't you get a blood pressure cuff at home? You can get it from Amazon for, 20 quid, they're not much. You can get it done by your GP. Checking your bone out, general bone health, okay? No alcohol, well, that's unkind, isn't it? Reduce your alcohol, okay? Make sure you've got a decent diet with lots of kind of calcium in your diet. Get some sunlight, get some vitamin D from boots if you can't get sunlight. Keep an eye on your skin. Get your partner to keep an eye on your skin. Any lumps or bumps that are growing or changing, get somebody to point them out to you and, get referred on. Baseline vision assessment and then annual visual monitoring if you've had an optic pathway glioma. Probably the rest of us can probably cope with 2 yearly. If you're female, examine your breasts every month. So far in 10 years I've picked up breast cancer in one male individual as well. So, breast cancer occurs in blokes as well. Try and get some sleep. It will improve your headaches. Use resources like Neurofibromatosis UK as a way of educating yourselves and keeping abreast of what's going on in the world. Make sure your emotional well-being is kept up to date, okay? Depression, anxiety are eminently treatable things, are things I've had in my past, and I know how bad they affect your quality of life. So get them sorted out. You've got support from the clinical nurse specialists, from the service we have in Manchester and the team in London. And I say, there's support out there for you. I know Facebook's very popular, I'm on Facebook, but my one note of caution about Facebook is that Facebook's unregulated. So somebody could put something on Facebook which isn't actually true and you can be misled. So if you read something on Facebook which you're uncertain about, just check out with somebody, okay? I've got no idea how long I've talked for. I'm sure you're all bored to tears. I think that's about half an hour. So I'll leave it there. Any questions, I have to answer them. If you have any sort of personal questions, please don't ask about your bladder control when I'm standing up here, because that could be a little bit embarrassing for you. I'm happy to answer questions privately over lunch, etc., until I leave at about 3 o'clock. Thank you.